I will now move on to our next speaker, Dr. Sherri Hayden, a clinical neuropsychologist who has been with the clinic longer than I have, which is a great feat, and we really appreciate Dr. Hayden's input in the management of our patients, and she in particular has excellent background and skills in helping people cope with some of the emotional changes they're experiencing when not only living with dementia, but also at risk for dementia or concerned about dementia. Please take it away, Sherri.
Thank you. Good morning, everyone. And I'm very pleased to be here today to talk to you about mood and behavior in dementia. This is a very expansive talk that I have to squeeze into 15 minutes, so I'll do my best. But before we begin, I'd like to just remind us that when it comes to mood and behavior in dementia, the only constant is change, which we're certainly learning more about during this COVID time. We do know some basic tenets of behavioral issues in dementia, and that is that the different variants of dementia have differing behavioral issues, particularly along the course of the illness. So there's a lot of variance in how people behave, a lot of individual differences. Although 80 to 90% of people with dementia develop at least one distressing symptom over the course of their illness. It's important to remember, though, that some behavioral disturbances are potentially treatable and at least manageable, so it's important to anticipate them and recognize them early. There are many different types of behaviors associated with dementia-related disorders, and many of them are listed here. What I want you to remember is that for some people, they may have little or none of these symptoms, and for some people, they may have many of these symptoms. There's, again, a large range. But the timing of the behavioral symptoms are differentiated depending on the stage of illness. So early in the course of dementia or prior to diagnosis, you'll see more mood-related symptoms like depression and anxiety, and the consequent issues related to those issues like sleep disturbance, agitation, apathy, and mood swings. Later, to the mid to late stages of illness, you'll see symptoms related to the progression of the patient's symptoms over time. What I'd like to do is remind us that mood, when I'm talking about mood, I mean things like anxiety or depression, is very complex, and we identify and it is reflected through our behavior. So I'll be focusing more on behavior today so that you can understand how to navigate issues that you might face. The basic thing you need to understand is that all behavior has meaning. It's common that behavioral disturbance is a way to communicate an unmet need or unspoken need or issue. And that could include things like feelings of fear, frustration, sadness, or anxiety early in the disease process. Or for some, it's a way to communicate that something's not quite right, or they don't understand what's being communicated to them, usually later on in the illness. You can see reinforced behaviors that have been inadvertently reinforced. So an example would be someone who screams and gets attention will continue screaming. And it's not uncommon that the behavioral challenges that we face in dementia represent a mismatch between what's going on in the environment and the person's ability to understand and respond. It's quite important that we understand the triggers to the behavioral issues if we're going to manage them. And we can categorize these into 4 different areas: medical, psychological, behavioral issues related to cognitive change, and environmental triggers. So when we talk about medical triggers, we're talking about issues such as illness, a fever, pain that can cause someone to become agitated and affect their behavior. But it may also include things that we don't think about, like side effects to medication, pain, wounds, infection, that sort of thing. When we're talking about psychological triggers, there tends to be a difference between early stage or prodromal pre-diagnosis stages and later in illness. Early and pre-diagnosis stages of illness, you're going to see a lot of issues perhaps with fear or anxiety about what's to come, grief or depression about the loss of cognitive skills in the person, or changes that these things have impacted their life. There's also something we call anticipatory anxiety, which is when someone is anticipating that they're going to have trouble in a situation. A good example is someone with language problems might avoid or become quite anxious before a social gathering because they're anticipating failure in communication in that situation. So it's important to understand that. Later in illness, the psychological triggers tend to be related to frustration as a consequence of the cognitive change that they're experiencing. So the cognitive triggers are really all of those changes that are symptoms as part of many of these different forms of dementia, things like forgetfulness, inattention, decision-making issues that all cause that person to misinterpret the environment or misunderstand what is being said to them. So it's important to understand that. We're going to take a closer look at these different issues though, so that you can understand what you might see. So an example would be if someone is forgetful, they would likely not follow rules or follow instruction, not because they don't necessarily want to, it's just that they've forgotten what was just said to them. Obviously, you'll see things like repetitiveness and a lack of continuity. So what happened this morning will not make sense this afternoon to them, even though those two situations might be linked. People with attentional problems maybe get overwhelmed or overstimulated if there's too much going on at once, and this will cause forgetfulness later on. People who have trouble judging where things are in space are at high risk for falls and getting lost. As I mentioned, those who have difficulty expressing themselves can become quite frustrated and agitated as a consequence to that. On the other end of language disorders, people that have trouble understanding or comprehending instruction may again not follow rules or not follow instruction because they haven't understood what was said to them. They may have trouble with there may be problems related to their comprehension in providing care. So an example is if someone is getting assistance to have a shower and they have comprehension problems, they may not understand what you're saying and that you're going to undress them to have a shower. And that might lead to feelings of fear or suspiciousness. And there are many people, including frontal temporal dementias, that have trouble with what we call cognitive shifting or transitions. And so when there isn't predictable events happening, if there's spontaneity, it can lead to agitation, and they can also become quite overwhelmed if there's too much going on in the environment. There are many environmental triggers that you can think about. If you look around your room right now, you might see that the lights are too bright or too dim. If there's a TV in the background, that's distracting. If there's a lot of clutter. All of these things can create challenges to behavior, and then the person may become agitated. The things that we don't think about are things like shiny, clean floors might look nice to us, but they can look like water or ice to a patient. Furthermore, issues like mirrors, some patients further in the disease process might have difficulty recognizing themselves and become distressed when they look in the mirror. Too much or too little contrast in color. So an example is an all-white bathroom can make it difficult to distinguish the toilet from the seat or the wall. On the other end of the spectrum, too much color contrast, such as a two-toned carpet, can make it look like there's holes in the floor, and that can be distressing. And as some of you may know, moving homes or rearranging objects in the home can be distressing as well. So what can we do? Well, there are some things that we can do, and I'm going to be focusing on non-pharmacological approaches to behavioral issues. So they are really defined by what they are not. They are not using medication, but I would like to say that there are certainly circumstances for both mood and behavior that medication is very, very helpful. But that said, these approaches really involve an action to manage those triggers that we've just talked about. And I'm going to be focusing on more generalized approaches as well as behavior-specific approaches to managing behavior. So what we need to remember when we're thinking about management of behavior is that we need to understand the context of the behavior. That's why we reviewed the triggers. We need to know what those triggers are so that we can best determine the approach that will work to manage that behavior. We also need to consider the stage that someone is at. So you will speak very differently to someone in the later stages of illness versus the early stages of illness. So it's important to remember that. And perhaps the most important thing for anyone that's trying to navigate challenging behaviors in their loved one is self-care. In order for you to manage this in the long term, it's really important that you take care and recharge yourself. Now, when we're approaching behavior, it's also important for us to reflect on our own behavior. It's very difficult to do, but it's important to try to not take negative behaviors personally. And what might help that is to remind yourself that it's a symptom of something bigger. Try not to, whenever possible, correct or argue with someone unless it's a safety issue. In other words, choose your battles. And keep in mind that some of the things that you are expressing, so if you're feeling rushed or you don't want to give too many choices because it's going to take too much time, that can create some negative experiences for that individual as well. Now, as I said, what's important for you to do is to always look at the environment and inspect for triggers in that environment, some of those things that I mentioned before, and then think about ways that you might correct for that. Obvious things would be making sure that someone has their assistive devices so they don't misinterpret the environment. So making sure they have glasses and hearing aids, using visual reminders, so signage for important items or rooms in the area. We know that structured daily routines that are predictable are really important and help to compensate for issues with memory and trouble with shifting. Tapping into activities that a person is strong in or has previous interest in is also quite positive. Later on in the illness, as we're trying to manage behaviors, we often look at repetitive motion activities that can distract someone from negative behavior. So things like folding towels, putting coins in containers and such. And just recognize that if you start an activity for some people, especially people that are forgetful or have trouble with initiation, you might have to help them get started. And this is a busy slide, but I'll just take a few minutes to go through behavior-specific interventions because I think it's important to have some examples to understand how we can manage. So when we talked about difficulties with, for those people that have difficulties with finding words or names or expressing themselves, it's important to give a little extra time to allow them to respond. It can take up to 30 seconds or more for someone to respond. And if you jump in too quickly, it can lead to frustration and agitation. Identify their feelings and acknowledge that if someone is feeling frustrated or embarrassed. And you can offer to assist by, can I help you with that word? But always ask for permission first. When we're talking about forgetfulness, there's obvious things like memory aids and daily routines that will help. But as we move further in the later stages of illness, it's important also to recognize that asking someone to remember you without leading with your name can be quite frustrating and embarrassing and agitating. So, you know, always starting with who you are if they don't see, particularly if they don't see you often. Someone who's repetitively questioning can be quite frustrating for caregivers. And the workaround for that is always to use a calm and reassuring voice. I would also say self-care is important so that you get breaks. Inform of events that as they occur, don't say what's going to happen in the future because you'll get repetitive questions about that. And use distractions whenever possible. For those people that have trouble understanding language, keep it short and simple. And use visual or tactile cues to gain their attention and show them. So you would demonstrate brushing hair, that sort of thing. If I ask patients about their hearing, I point to my ear. Think about your tone and your volume and your body language. If you sit like this and you're frustrated, even someone who has trouble with language is going to read that and might get agitated as a consequence. And if you can avoid pronouns, particularly as the disease progresses, this will be helpful for someone who has trouble understanding. So using Susan said this instead of she said this is going to be much more helpful. And for those who have trouble with confusion in recognizing objects, know that there are certainly workarounds for that, such as labeling objects, removing, showing a patient objects one at a time rather than having several, and keeping everything in order so that it's easier for them to understand. So I just wanted to say that There are many behavioral challenges in dementia and mood changes that can come with dementia. And although I wasn't able to go in depth in anything, I hope some of these suggestions can help you. And I certainly am happy to answer any questions. Thank you.